the chairperson of second technical session. May I request to Mr. Milan Gurung sir to take a seat of the session. Second, Mr. Milan Gurung sir is CEO of Neuro Hospital Kathmandu. Please have a seat, sir. So for the first presentation of second session, may I call to Mr. Sudhir Thakur sir, the Chief Director of Lahan Eye and Ear Care System. He is a BSCM and MSCM graduate of NOC College. And topic of his presentation is From Struggling to the Strength, HR Innovation at Lahan Eye and Ear Care Center.
Sir, I think it will be good if you will inform our colleagues who are still taking the lunch will come soon to participate in the program. Otherwise, this will go till 3 p.m. If you will not push them, we will not able to start on the time. Gentlemen, shall we start?
Sure.
Thank you. Good afternoon. My respected gurus, Sheetal sir, Panjiyar sir, my friends, colleagues, and our distinguished guests from India. Are they here?
Yes. He is already here.
Okay. So, thank you very much for supporting National Open College, because the relation of Nepal and India has been started in Satyug, when King of the Ram, Ayodhya, got married to the Janaki of Janakpur. So this relation is historically and culturally since long time. And second thing, there are more than 6,000 rivers of the Nepal, which water flows to the India every day. And 40% of the Ganga water is from the rivers of the Nepal. So Nepal and India can fight each other for some time, but they cannot live separately. So God has made us in such a way that we have to work with them. We cannot separate. So this is the initiative in the healthcare management also from IHSMR to support Nepal in healthcare management, and this will further strengthen the healthcare management services. So now I am going to my topic. This is From Struggle to Strength, HR Innovation at LEAGS. Then HR scarcity, now HR excellence through in-house training. So I will share you, it's the challenging session for me because it is after post-launch. I think Sheetal sir has purposefully put my session after the lunch so that I will not able to make you sleep. So this is a challenge for me also, and hope you will support me in achieving my challenge. Thank you very much. So now going to the topic, I will share you the journey. So this is a story of improving human resource development, retention, performance and motivation. Once challenged by limited human resources, LEAGS has transformed into a powerhouse of talent, training, nurturing and shaping professionals across all domains. We all know hospitals are complex organizations. They unite diverse professionals from housekeeping to highly specialized medical experts, managing diverse skills, roles and expectations while ensuring seamless patient is a major HR challenge. So now I am taking back to you 43 years ago What was problem when we have started the eye care services in the Lahan in a very remote places where there was no water available, there was no electricity available. So what was the problem of the Lahan, not Lahan, Nepal, 43 years ago? The prevalence of blindness was 0.84%, and the blindness, especially in some zones, Kosi, Sagarmatha, Bheri, Karnali, it was 1%. So out of about 1 out of every 100 was blind. 43 years ago, many of us were not born at the time. Nearly 167,000 people were living in blindness in the Nepal. And what was the resources? 10 ophthalmologists, 2 optometrists. It was a long waiting time to get the cataract surgery operated. People have to wait 1 year to get the cataract surgery operated. Because of that, people were going to Sitapur in India, near to the Gorakhpur. It was very famous for the eye surgery at the time, for the cataract surgery. So 1983, one German ophthalmologist, Dr. Albert Henning, came to the Lahan with his family and 2 spouses. He came to Lahan. There was no human resource available because 10 ophthalmologists and all other human resources were working in the Kathmandu. Blindness survey showed that the problem is in the plain area, out of the valley, but the trained human resources were in the Kathmandu. So he started with a vision to restore sight, but without trained manpower. No skilled ophthalmic team, no structured HR system, high need of the services, but very limited capacity. Instead of waiting for the talent, he created it, selected young students of the local community who passed the 10th grade, trained them in ophthalmic care from the ground up, and built confidence, skill, and purposes. So you can see, he started with the 12 beds, and then he has to expand, and temporary mud house used to admit patients after the surgery. He came with all the equipment from the Germany, but there was no electricity in the Lahan. Many blind people are waiting in the Lahan for the cataract surgery, and then he started with the torch light. You can see 43 years ago, there is operation theatre light, but was no electricity. Then patient number increased, and with support of the CVM German organization, 50-bedded eye hospital was constructed in the Lahan. Organization grew, patient load increased rapidly, but HR remained limited, creating a critical challenge at the time. The HR gap became a major barrier to sustainable service delivery. Then he introduced several types of the training program and attracted young ophthalmologists from Nepal and India. Launched a sponsorship for MD programs. By 2080, the hospital had grown into a 450-bed institution. More than 50,000 surgeries were performed each, restoring sight, hope, dignity to countless lives. Over 2 lakh outpatient visits annually highlighted the overwhelming demand of the eye care services. Along with this rapid growth, the human resource gap became more severe, making it increasingly difficult to meet the rising service load. Lahan retention problem was also the main problem. Lahan Eye Hospital grew up, but there was no still good schools, good medical education available. So at the time, the team suggested that we need to have one eye hospital in Biratnagar where there is every facility available, where the doctors can stay. So we have started the eye hospitals in 2006 in Biratnagar. What strategy we have taken to combat all the human resources challenges in Lahan from struggle to the step. So these 4 are the 4 key strategies. I think in all human resources book, the strategies are only written but not explained that how it can be implemented. So here we can see how it has been really transformed the lives and the strength in the organization. One is human resource development. Second is retention. Third is the monitoring and evaluation. Fourth is the digitalization and continuous improvement. These 4 strategies has changed the whole situation in our organization. What we did in organization development is started training programs from basic to advanced. We have started all types of programs. Local people started to join the program. Second, established an internship and on-the-job training program. So you can see, 1999, 27 years ago, we have started first time in Nepal anti-racing fellowship. 2008 Retina fellowship, 14 diploma in ophthalmic science, 2015 MD in ophthalmology, 2018 BSc in optometry, and 2020 subspecialty. So all types of human resources which we need are produced locally in the organization. Not only those, there are many several skill-based trainings are also organized nowadays. Second, retention stay. So we all know Maslow hierarchy of the need, aligning individual goals with organization goals. When individuals' needs are met, people naturally work toward common goals. So just like stagnant water, stagnant organizations can become toxic environment. So the solution is to offer more levels in your company and a clear pathway to the advancement. So what do we do? We had 20 levels, now we made 18 levels. So every 5 years, those staffs who are performing are promoted to the next level. So they do not think demotivation, they always think performing good can give the opportunity to increase on the higher level. What other retention strategy we did? Structured development, clear pathways, focused retention strategies for the ophthalmologist and other key levels. Performance-based salary system we have initiated. Annual training plan we have started, and conference participation to our speakers to the national and international conference are the other key strategy for the retention strategy. Third step, monitoring and evaluation. We have made a clear job description. Define key performance indicators of every task, regular performance evaluation, feedback and review, action for improvement, and recognition and reward were the third major steps which made us continuity of the services. Fourth, very important, digitalization and continuous improvement. We have started digitalization of the HR system, continuous improvement in training and development, and we have the standard operating procedures of every activities and the department, which has improved the utilization of the human resources. We are the first in Nepal who have started first ophthalmic digital training hub, first of kinds in Nepal. So there is a very popular quote, tell me and I forget, teach me, I may remember, involve me, I learn. So this digital training hub brings the philosophy to the life, and this is the same life. The pilot is trained before having the live flight. Similarly, we are also providing training to the ophthalmologists. Before going to the operation theatre, they have the simulator training at the lab. And last year we have started, first time in Nepal, fellowship in eye healthcare management for the master's graduates. So what impact this has created? You can see we have now, when Dr. Henning alone came in 1983, 43 years ago, he was alone. There was only 12 beds eye hospital. Now we have the 2 centers of excellence eye hospital, one is in Lahan and another in Viratnagar, and 40 primary eye care centers and several community programs. We have reached last year more than 40 lakh people, and we have performed more than 132,000 surgery. This is the highest in the Nepal. And not in the hospital list, if you see, we have varieties of community program, and we have reached more than 7 lakh people in the community. We have all type of subspecialty of the eye, cataract, cornea, vitreoretina, glaucoma, arthroplasty, everything, A, B, C, D, E, F, Z. Therefore, people of Kosi Pradesh and Madhya Pradesh no longer need to travel outside for the eye care. And we have all types of the training program. MD residency, anterior segment, vitreoretina, cornea. So what the impact has been continued, we have achieved self-reliance in developing eye care human resources. From paramedical staff to MD ophthalmologist super specialist. Second, develop thousands of skilled professionals serving in our institution across Nepal, India and other countries. Played a major role in strengthening eye care ecosystem in Viratnagar, where the number of eye hospitals has grown only in 2006, more than 20 today, with many professionals trained at our institution. Created thousands of employment opportunities within the organization and beyond national borders. Eliminated critical human resource shortage, ensuring sustainable growth and unlimited quality eye care services. So 1981, we have seen one small clinic in general hospital with 12 beds, one ophthalmologist, no outreach community activities, no surgical training. Now, 2 centers of excellence and 40 eye care centers, 950 bed eye hospital. 965 human resources are working in our organization. 325 screening camps are done. 2 years anterior segment, every types of trainings are available there. So this is not the one in Nepal, this is the world 3rd largest cataract surgery program in the world. So what do we learn? Human resource development must be a continuous and evolving process embedded within the organization culture. You can purchase everything, equipment, building, but human resource you cannot purchase. We have to make an environment to work them more effectively and efficiently to utilize your equipments and the resources. Second, employee retention and organization growth should progress together. If you make people run only for your goal, they will get tired and stop after some time. But if you align their goals with your they will keep moving with you for a lifetime. As organizations expand, strong HR system become essential, including clear job description. Regular monitoring, supervision, and feedback mechanisms are critical to maintain. So what honors and awards we have received? You can see in 2013 we have received International Polymorph Vision Award for the prevention of blindness. This International Polymorph Vision Award is often regarded as a Nobel Prize of Ophthalmology, recognizing outstanding contribution in the field of vision science and eye care. And these awards are many, but creating smiles on countless faces is our great reward, greater than any recognition in the world. You can see in the picture, after 10 years of darkness, his son finally sees his mother's face again thanks to the life-changing surgery at the camp. Can you please play this video, Maharaja? Next one. So this is the one of the child, but there are many thousands of people which lives is transformed because of the human resources that has been developed in the 43 years by the organization. So I am on last. Most important thing I have purposefully written in the Nepali. तपाईको टोलीमा रहेका कर्मचारीहरू धेरै ध्यानपूर्वक हेर्नु होला. केवल तलबका लागि काम गरिरहेका छन् वा तपाईको साथमा आफ्नै लक्ष्य र सपना पूरा गरिरहेका छन्. यदि उनीहरू केवल तलबका लागि काम गरिरहेका छन् भने उनीहरू साँझ घर फर्किन्छन्. तर यदि उनीहरू तपाईको साथमा आफ्नै सपना पूरा गरिरहेका छन् भने उनीहरू जीवनभर तपाईप्रति समर्पित हुन्छन्. आगो पछाडि नलगाउनुस्, आगो छातीमा जगाउनुस्. पछाडि आगो लाग्दा मानिस जल्छ, तर छातीमा आगो लगाउँदा इतिहास बन्छ. So you can see, because of our human resources, thousands find light each day. They are not just hands at work, they are the hearts that restore sight and hope and life. यहाँ हेर्न सक्नुहुन्छ डक्टरिङ 1983 मा आउँदाखेरिको र 2012 मा चाहिँ रिटायर हुँदाखेरिको तस्बिर छ. उनी एक्लै आए, न कुनै नामसँग, न कुनै ठेगानासँग. शून्यताबाट सुरु भयो एउटा सपना महानसँग. आज त्यही सपनाले हजारौंलाई साथ दिएको छ. अन्धपनसँग लड्ने हजारौंको उज्यालो सेना बनेको छ. नेक्स्ट टाइम
उड़ती पतंग सा खाबो, कहाँ गया उसे ढूंढूं. कल की फिक्र सताती, वो बस आज का जश्न मनाता. हर लम्हे को खुल के जीता था वो. कहाँ से आया था वो, छुके हमारे दिल को. कहाँ गया उसे ढूंढूं.
So it is not just a profession, it is a revolution in HR development that changes lives, transforms possibilities, and redefines what people can achieve together. वहाँ फर्किनु हो, तर हजारौं सेना चाहिँ नेपालमा तयार गर्नुभयो जो अन्धरूपी ब्लाइन्डनेसलाई लड्नको लागि अहिले पनि फेल भएछ. थ्यांक यू भेरी मच.
Thank you so much, Sudhir sir. So our next presenter is Professor Engineer Kapil Gautam sir. He is the CEO of Nepal Cancer Hospital as well as MSc graduate of NOC College. The topic of Professor Engineer Kapil Gautam sir is cytotoxic waste management in National Cancer Hospital, Kathmandu.
Next one, wala.
First of all, very good afternoon to respected dignitaries here, Chairman, session, and all of my co-workers, students, teachers. First of all, I would like to request kindly allow me to present my topic in Nepali language, because I want to present this topic in local language, because this is something related with the very local thing. So actually this topic, this cytotoxic waste management, we are in Nepal, we are talking about the waste management only, but this cytotoxic waste management is a very serious concern actually. So many people are getting infected with this cytotoxic waste because we are not properly dealing with them, and the worst part is that the people who are infected with these things, they don't know about these things. So this is a great, I think it's a great responsibility also to all the people who know about this, and then this is also the social responsibility to the entire nation as well as to the entire humanity too. So as Nepal Cancer Hospital is established with the vision statement Nepali ko cancer upchar Nepal ma nai. So we deal with the cytotoxic waste management, and the other part what I want to discuss is that I have been in this field since last 24 years, and what I have been trying is that this the collaboration of the various hospitals in Nepal itself, where we can learn together, where we can share the knowledge and experience so that we can learn from the mistakes of each other. But I am very sorry to say that the platforms have not been properly built up and we are able to practice their things. So again, request from this platform again to let's start talking with each other. Let's try to share the knowledge and information with each other so that we can learn together. So because of this reason, I have decided to present this topic today, where I'm going to share the data itself too. Next slide, please. So just start, what is cytotoxic waste? So cytotoxic waste means cancer related जति पनि वेस्ट जेनेरेट हुन्छ, जति केमोथेरापी ड्रग्सहरुसँग रिलेटेड वेस्ट जेनेरेट हुन्छ त्यसलाई चाहिँ हामी साइटोटोक्सिक वेस्ट भन्छौं। र यो साइटोटोक्सिक वेस्टले हाम्रो चाहिँ धेरै म्युटेनिक इफेक्ट देखि लिएर हाम्रो चाहिँ कार्सिनोजेनिक इफेक्ट सम्म गर्न सक्छ र त्यसले चाहिँ क्यान्सर, बर्थ डिफेक्ट, जेनेटिक म्युटेसन सम्म गर्न सक्छ भन्ने कुरा चाहिँ अलरेडी प्रुभन। नेक्स्ट स्लाइड प्लिज। सो बेसिकली यसलाई दुईटामा हामी यसलाई क्याटेगोराइजेसन गर्छौं, एउटा साफ र वेस्टमा भनेर। सो जुन चाहिँ केमोथेरापी ड्रग्समा डाइरेक्टली इन कन्ट्याक्ट आएको चाहिँ निडल्सहरु, एम्पुल्सहरु छ भने अर्को चाहिँ सफ्टवेयर्सहरु, आइबिसिएस इन्फ्युजन ब्याग्सहरु छ। नेक्स्ट स्लाइड प्लिज। So this is the data what I am going to share with you. So this is the data between December 22 to November 23 that the Nepal Cancer Hospital has generated the cytotoxic waste, and you see the direct relationship between the number of patients and the cytotoxic waste generated. So the blue line indicates the total admitted patients, and then the green line indicates the number of kgs of waste generated in that particular month. Next slide, please. So here you can see we have calculated the rate of waste generation per patient. So it's 0.29 kgs to 0.26 kgs per person per month. And if you see the same trend 20 to 24 is drastically reduced here. So here now this waste generation is reduced to 0.16. Next slide. And this is the 24 to 25 data, the same similar data. Next slide. Next slide. Next slide. So whatever I am to show here is that there is a direct relationship between the number of patients and the cytotoxic waste generated. And then you see the data, they are decreasing day by day. Though the patient numbers are increasing, the waste generation is getting reduced. So this is where the management plays actually. So you see in the previous slide, or next slide. So you see there in the month of May, the waste has slightly increased from 0.18 to 0.2. The reason behind is that next slide. The reason behind is that previously we used to use that this plastic slide bottles for the chemotherapy distribution. The light sensitive drugs. But later on, what we found out that this photosensitive infusion bags are more standardized than those plastic bottles. So we transform into this. Because of that, because of this material here. Because of this material, the weight has slightly increased. Next slide, please. So to handle this, to get this development or improvement in Nepal cancer hospital, actually we followed these 8 different steps to reduce the cytotoxic waste generation. So this is the handling in mixing room where actually the waste are generated, and this is the cytotoxic color coded plastic bags where we collect the cytotoxic waste. And then what we did actually, this is what actually I want to share with you, what we did to reduce this. So first we started the training for the nursing staffs, because they are the one who actually mix the things. And then we train the healthcare waste handlers who handle the waste. And then training to the housekeeping staff. So these 3 people, we train them, and then we not only classroom training, we also go the in-person training also, on-site training also, with the regular monitoring and the regular feedbacks and regular award system too for them. So you see, this is the before the minor segregation. You can see that many things are mixed up. So this was the data of 22-23. Because of this, the weight was increased there. Then after the training and all that, this was the final output we got it. Because of this segregation, the segregation, the waste level was reduced. So this is the way we transport the cytotoxic waste to our waste unit. So we follow this 2020 Healthcare Waste Management 2020 guidelines, and then the Infection Prevention Control Manual 2020 for cytotoxic waste management. So we follow these guidelines to do this. And then another challenge what we face is that what we found is that for cytotoxic waste treatment, there are 4 methods are available: chemical treatment, encapsulation, sanitary landfill, and incineration. So among them, the 4th one not recommended by the government of Nepal as well as in the international society. Also now the incineration is not recommended, because what the incinerator we use here in this part of world is the actual incinerators. So because there is a 2-level or 3-level proper fully oxidation needs to be happen in the incinerators, but the what incinerator we use here, they don't need the full oxidation proper, so that they pollute the environment, so that among these 3 treatments, again the encapsulation and sanitary landfill again is not feasible, because we don't have the lines available in the city areas where we can encapsulate or we do the sanitary landfill. So we practice this chemical treatment. So we use actually sodium hypochlorite 5-liter solution to neutralize the cytotoxic waste. So the recommended concentration for defective disinfection is 1:5, and then we submerge those cytotoxic waste for 8 to 10 hours. So this is the method how we do that treatment process. Actually, this is done by the waste handlers in the waste management department. So these are the people, actually the main people who do these things. So I'm really thankful to them, because these are the people actually who made these things happen, and then I'm thankful to them. The actual reward goes to them. So this is the way we develop and we practice the things there. So these are the containers where we dip the cytotoxic waste in the this sodium hypochlorite solution, and once after 8 to 10 hours, there is a tap water. So we put those solution in the full tap water so that the dilution will happen, and then after dilution only we separate the waste. Thank you very much.
Thank you, Professor Engineer Kapil Gautam, for your presentations. Next will be rethinking patient safety from the top, the clinical pharmacist's role in reducing medication error in Nepal. So we'd like to invite Dr. Sunil Shrestha. He is a PhD pharmacy research scientist and senior clinical pharmacist. The time is yours.
Good afternoon, everyone. Respected chairperson. So I'm Dr. Sunil Sreshya, head of research and academics at Kathmandu Cancer Center, and I'm a clinical pharmacist who has spent almost 1 decade working on medication safety here in Nepal. I'm speaking in a hospital management session today, and that's a big opportunity for me because the problem I am about to describe here cannot be solved by the pharmacist alone. It requires a decision that only hospital leaders, hospital manager, hospital administrator can make. So we'll move independent research groups. So, coming to the medication reconciliation, this is the one of the most evidence-backed intervention is medication reconciliation, where clinical pharmacists verify a patient complete medication list at every transition during admission, ward round, ICU transfer, discharge, and cognitive follow-up. A 5-hospital study found that expanding the pharmacist rate discharge reconciliation reduced our 30-day readmission from 18% to the 15%. So there was also a reduction in the adverse drug reaction, which was up to 67%. And now coming to the adverse drug reaction reporting and the pharmacovigilance. So in 2018, while I was working in one of the reputed cancer hospitals in Nepal, I started a regional pharmacovigilance center in oncology-based hospital, and we also provided some training to the nurses, pharmacists. So this is one of the core area. So there are lots of adverse drug reaction, especially in the oncology. So this is the most one of the area. So now coming to the Nepal specific cultural challenges. 6 structural gaps hold us back. So first one is the pharmacist force gap. Second one is regulatory and curriculum lag. Third one is the polypharmacy and the burden of the cancer. Fourth one is that we have a very weak area reporting culture, and I guess most of the audience doesn't know what is the pharmacovigilance. And the fifth one is we have a lack of infrastructure, and sixth one is the research. So technology amplifies the pharmacists but doesn't replace them. Computerized order entry and clinical decision support systems are increasingly affordable and reduce errors significantly. So what the hospital leader must do? So in the next 3 months, if you want, you can appoint a clinical pharmacist, and you can launch a medication reconciliation at every admission, introduce a no-blame area reporting form, run a baseline medication error audit. None of this requires capital, it requires a decision. Within a 12-month, define clinical pharmacist description tied to the bedside role, not only dispensing, but also let them participate in the ward round. And over to 1 to 3 years, clinical pharmacists can be incorporated with every multidisciplinary team meeting, and we can link you can also link your hospital to the pharmacovigilance system, which is national and international. So 6 things to carry away. So first one is medication errors are massive and mostly are preventable. Around 238 million events a year, $42 billion cost. Second one is the evidence shows that if clinical pharmacists are embedded in the multidisciplinary team, there is a less chance of readmission, and there is a reduction in the drug-drug interaction. There is also reduction in the adverse drug reaction. And the third one is Nepal gap is structural, not a talent gap. We have lots of clinical pharmacists, and we have not given them a proper role. And fourth one, medication reconciliation at every transition at the single highest impact, lowest cost intervention available today. Fifth one, we have already proven this model works in Nepal. We have PharmaCap model in Kathmandu Cancer Center, and we are working efficiently in the cancer care. Sixth one is the hospital management was the key job description, multidisciplinary team integration, institutional culture, and college to invest. So I want to leave with the line on this final slide as, so patient safety is not a development, it is the duty of every healthcare leader, administrator, management, human resource. The clinical pharmacist is your ally in that duty. Thank you very much.
Thank you, Dr. Sunil, for your presentations. It was very insightful. Now I'd like to call Mr. Mahendra Bhushal, who is a MSCM and Bachelor graduate of NOC, and he's the Managing Director of Healthcare International Consults Private Limited, and he's going to talk about hospital design, future-proofing healthcare space. Mr. Bhushal, this is your time.
Respected Chairperson, Sital Sir, Panjayar Sir, Lagat Sampura, Guruvaru, my seniors, juniors, and my colleagues. Today's my topic is future-proofing healthcare spaces for hospital in terms of hospital designing. My presentation will be based on the projects I have done in the hospital planning and designing. I have done in about more than 50 hospital projects in terms of planning and designing. So based on that, because of the time limitation, I have taken some of the highlights, some of the points, about 10 points are here. So how we can think or how we can build the modern hospitals in terms of talking about the futuristic, realistic hospitals in the concept of Nepal. Let's go through this. First of all, we need to see the global drivers, why we should consider the future hospital for future. So the hospitals we build today is not only for this period, current period of time. This is obviously that need to be suitable for the future as well. So one of the the global drivers is aging population. We need to meet the needs of the aging population, and climate change is burning issues at this moment. And similarly, the infectious disease such as like the COVID and something like this, infectious disease are the increasing day by day, and the artificial intelligence are existing in the hospitals in a modern time. So digital health transformation is also existing in the hospital. We need to address on that, and then increasing the patient expectations. Similarly, rising the healthcare cost in the modern contemporary time. So before we start, let's see the data up here. The biggest two natural disaster and calamities here, we all know that. So to the 2072 BS earthquake, that there was 9,100 deaths were declared, and around 22,300 were injured, and 8 million people were infected. So when we build a hospital, we need to see that consequences, how we can build the hospitals. Okay, so we need to. So next, so for that, so let's see the data here. It was taken from the Ministry of Health. So 544 health facilities were severely damaged. Health facilities. and 653 health facilities were partially damaged. So while preparing the hospitals today, so we need to consider the natural disaster and calamities that can be occurred in the future, and we need to protect from that disaster, natural disaster and calamities. Similarly, the COVID, look at the COVID incident, 1 million people were affected, and then 12,000 deaths were declared because of the COVID. So let's move ahead. Before we planning the hospital, we need to see the populations. Okay, so what sort of hospitals we are going to plan, and what sort of hospital we are going to design in that particular geographical areas. Whether we are going to build up the clinic that is by practitioner by single doctors, or that is primary hospital, or secondary hospital, or tertiary hospital. That determines, before we start the hospitals, we do the feasibility study. So that will give you the result, what sort of hospitals we require in the particular geographical area. So when we do the planning, before starting, the building the hospital, so we need to do the planning for that. If we are okay, look at the here planning part before we build out the hospitals. Before we plan the hospitals, we need to see the things here. So there are three different level of care level of hospitals. So one is primary care, and then secondary and tertiary care hospitals. Basically, three types of hospitals will be there. So in primary care hospital, there are based on the the role delineation level. So there are 6 categories of their role delineation level based on their nature of how they perform, nature of the hospitals, how they perform, and how they provide the patient care. So we categorize in 6 categories. So if we start the planning the clinic practitioner by single GP doctor or single doctor, now for these clinics we need to have the 5,000 to 10,000 of population, and then distance is up to 5 kilometers, and the access time to reach to the polyclinic is up to 30 minutes of driving time. Okay, next is the polyclinic and health centers. In private sectors, we call it polyclinic and health centers. So if we plan for the those type of facilities, we need to consider the population will be 100,000 to 10,000 to 100,000, and the distance is up to 10 kilometers, and the access time should not be more than 30 minutes of driving time. So let's go to the small primary hospitals. So these are basically 5 to 10, 15 bedded hospitals, up to the municipality hospitals up to 25 bedded. Basically, they would provide the primary services hospitals, and these are level 3 hospitals. So basically, when you talk about the population, those would be 100,000 to 0.5 million population would be there, and up to 15 kilometers of the distance, and the access time should not be more than 30 minutes of drive time. So general hospitals, general district level hospitals, and in private sector it is considered 100-bedded hospitals. So in government sectors it is considered secondary level hospitals, 50 and 100-bedded hospitals of the district hospitals at this moment exist in Nepal. So considering those areas, so this is secondary level hospitals. So when you talk about the population, it should be to 200,000 to 1 million population, and the distance is up to 20 kilometers, and the traveling time is 30 minutes drive time. So let's go to the next category, tertiary level hospital, level 5 RLD, and the major regional and provincial hospital. regional hospitals and provincial hospitals would be there, where they can perform the also perform the multi-speciality services and referral services up to there. So basically, when you talk about these hospitals, we consider the population 1 to 3 million of population, and distance is up to 100 kilometer, and the access time should not be more than 1 hour driving time or flight time. So last, these are the central level hospital, state referral hospitals, where we can perform the clinical research trials and the specialty, super specialty hospitals. So these are level 6 hospitals, and the population for those hospitals is considered 3 to 5 million, and the distance is up to 100,000 kilometer and 1,000 kilometer, and then the access time is up to 3 hours drive or flight time. This data was taken from the International Health Facility Guidelines, and when we plan here in Nepal, so we do follow that data when planning the buildings or hospitals. Now, when we have this data, now we have what sort of population is there and what type of hospitals we are going to build up. We have hand software data, and we do feasibility study, and then we think of what facilities or what features we can consider while planning the hospitals. So basically, some of the highlights I'm going to check here. So one of the things we can consider the smart technology in modern hospital planning. So what we can do is we think of the smart hospital AI-based robot system, whether we are going to fit those type of technology or not. So basically, what we consider is that sort of the modern hospital planning. We need to think of this. Basically, tertiary level care hospital and private hospitals, they would consider those aspects. So, for example, what could be there? So, electronic medical records system could be there. Nowadays, the AI system, they can monitor the patient vital signs, and they can record and analyze the vital signs with the AI system. AI-assisted diagnosis system. It is on radiology and automation lab system. So they would they can adopt those type of AI-based assisted diagnosis system up there. And automated pharmacy, and also the AI-assisted pharmacy would be there when we do the ordering and the minimum stock balance and all those things we can consider over there. And bed management systems also in the system they can exist. These are some examples like medicine, the medicine delivery to the particular ward with a robot assistant. And automated laboratory system, as I said earlier, and surgical robot surgery can be performed in the operation theaters. So next is modular planning and a flexible design. So basically, when you talk about the modular planning, so we do need to consider, so one piece of unit or department need to be equally divided to the another department. For example, if one OPD is 10 by 14, so all the OPD size of the hospital need to be 10 by 14. So if one hospital operation theater is, major hospital theater is 36 meters square, so all the hospitals, the major OT size would be there. So same size. So cutting like a cake. Okay, so we need to have an equal piece of the each piece should be each department should be equally divided. This is called modular, the planning. So, talking about the flexibility, so we need to consider about when we plan for the one unit, so we can maybe shift later on to the another unit. Okay, so by the changing of the time, so one surgical ward can be transmitted into the the medical ward. So basically, when the time requires, when surgical patient would be high, and then that can be converted into the medical ward can convert it into the surgical ward. So we need to think of this. So modular operation theater, as I said before, the modular with HVAC system and with HEPA filter and ELCU. So we need to consider for the IPC purpose as well, and we need to think of this. So low disruption and renovation. So when we convert into another service unit, so we need to have a basic, the adaptability and the suitability inside the premises. So patient-centered design and a healing environment. The patient-centered design should be considered something like this, not exactly I'm talking about. So that's one of the example what we designed, I have taken the photo of this. So something with this like family and friends, spaces should be there, they can come along. It depends on the how critical is the patient. And then normally critical care patient, we might not be able to this, need to be check and balance. So for the ordinary patient, we can consider those things. The family members, they can along around and they can give a company, and then the curing system will be the better. And the comfortable waiting area could be there, natural lighting could be there, and a quiet environment should be maintained, universal accessibility should be there, easy wayfinding guidelines and a navigating system should be there, indoor gardens and courtyards should be there, and water fountains and those type of things, and daylight access and natural views we need to consider while planning the modern type of hospitals. So look at this. Traditionally, how we used to plan the wards like this. This is one of the medical ward. We used to have beds right and left, and then the people used to be in this particular big wall, then a big hall. So now the time has changed, especially after the COVID. So it has been, the categorized all grid, each and every grid should be converted into the, the modern hospital wards or hospital beds. So in one grid, you can make one or two, the IBD beds. You can place it and a single bed, double bed system. We can place there. So basically single isolation ready rooms and double occupancy rooms and family accommodation can be considered over there, and better nursing observation should be there. If we do that, the improved patient dignity, it improves the patient dignity and reduce the hospital acquired infections and better communication and increase the patient satisfaction as well. Let's talk about the isolation facilities and infection prevention and control. Especially this issue has been raised after the COVID-19 infections. So when we do that, so we need to consider the negative and positive air pressure control systems. So separate infectious OPD should be maintained over there, and a clean and dirty corridor should be there, and hand hygiene station should be there, and proper waste management system should be there, and dedicated toning and doffing should be there. These are some examples I'm sharing here, and this is here with the negative air pressure. And some of the, when you talk about the not only the negative air pressure, so we need to think about the positive air pressure as well. So when you put anyone into the ward, like a patient suffering from burning case, so we need to keep it into the positive air pressure. So we need to not only the negative air pressure, we need to think of the positive air pressure, and basically three types of the isolation will be there. Standard, negative, and positive isolation should be maintained inside the hospitals. So next idea is talking about a suitable, the green hospital, sustainable and the green hospital design, smart energy and utility management. When we plan the hospital, so we need to think of the the green environment, the natural resources, natural solar power and the rainwater harvesting system we can consider over there, and then the wastewater recycling system we can consider over there. So energy efficient HVAC systems we can consider over there. Lead light, green roofs, and a natural ventilation should be maintained. It's good to have natural ventilation, and the intelligent lighting system should be there. Intelligent lighting system, for example, if anyone coming along the hospital, so that the light system can be automatically on, and when it goes off, so the light can be goes off. Automatic system you can fit into the hospital lighting system. So mental health friendly spaces. Traditionally, the mental health patients used to put it into the separate, the isolation area. Now the concept has been introduced that we cannot separate them from the hospital premises. Okay, so we can have the mental health patients in the hospital premises with a facility of the psychiatric consultation separate rooms, and the counseling center should be there, and then quiet therapy, the quiet therapy gardens should be considered. So they can go along the gardens and they can they can have a sort of retreat feeling environment, and stress relief rooms could be considered, like meditation, yoga, something room we can consider over there, and then family counseling areas should be there, and the dementia friendly environment should be maintained inside the hospital premises in the hospital building. So another concept we can add up in the modern hospitals is telemedicine and digital health integration. So now the concept we can do is for the if someone is is coming on the way from the far remote area to Kathmandu, and some of the procedures we can do at the like Rolpa or Jumla, we can do basic procedures over there over the telemedicine, and then they can come over here for the tertiary level care. For example, if anyone is the organ transplant patient, some of the basic diagnosis, counseling, and all those procedures we can do it while they are in Jumla or Rolpa or Kaligod, and then when at the time of the transplant, they can come in Kathmandu, and until this time we can consider the online, the consultation. We can do the consultation. Similarly, we can do the remote ICU monitoring system, e-prescription, mobile health application we can use there, and home monitoring devices we can use if we need, and digital appointment system could be considered. So home-based medical services, integrated community health networks. So basically, another rising concept here in Nepal is growing now. So I have involved more than 10 home-based medical services organizations setting up these services. So what we can do is, hospital is not only at the center, we can connect these services to the surrounding community people. Okay, for example, we can provide them home nursing services, home physiotherapy services, palliative care at their own home, and home sample collection we can do over there, and medication delivery, remote patient monitoring system, and community outreach and chronic disease follow-up system can be introduced at their own home. So now the time is considered to reach up to the home, not only stay in the hospital system. So another thing, last one is the disaster relief hospital design. So everything finishes, and till that time, the hospital should remain safe. So that's why when we plan the hospital, so we need to consider the hospital design, and the earthquake resistance structure, flood protection. We see last year here with some of the hospitals were severely affected by the flood. So we need to have protection, and we need to think of this before we build up the hospitals, before we plan the hospitals. So backup generators, reductant oxygen system, so emergency water resource system, and the helipad system also can be considered. Okay, so when the disasters happen, so we don't know what will be happen, so we need to be prepared for that. So last key message, the hospital of the future is no longer just a building. It is an intelligent, flexible, sustainable patient center, digitally connected, community integrated healthcare ecosystem that delivers the right care at the right place at the right time. I have some small clips up here. Please play it. Some of the hospital projects highlights are here. One of the provincial hospital in Lumbini Provincial Hospitals, which is 1,000-bedded multi-speciality hospitals, is considered as with oncology, separate 100-bedded oncology, and the cath lab, a separate cath lab system.
रेडियोलोजीको गहिराइदेखि लिएर मेडिसिनको तर्कले प्राणलाई जोगाएर यो केवल टीका होइन, यो टीका सुरक्षा हाम्रो हुनु आधार
Sterile corridor, negative hawa, isolation तयार छ पूर्ण हेरचाहको दाबी रोबोटिक सटीकता जाँचले क्रिया चल्छ मोड्युलर वार्डहरू आवश्यकता अनुसार बदलिन्छ लुगा लगाउने र फुकाले नियम कडा छ संक्रमण रोकिएको छ सुरक्षित मात्रै जाखडा छ यो केवल किता होइन यो केवल आधार हो सही हेरचाह सही समय सही चार्ज फेरेको छ उकार हो मेडिकल सिद्धता यो नयाँ नौका बिरामीको सुरक्षा हाम्रो हुनु आधार
टेलिमेडिसिन अस्पतालको पर्खाल भन्दा बाहिर पुग्दै रिमोट आइसियु हरेक पुकारको जवाब दिँदै घरमा स्लाइन अक्सिजन समुद्री स्वास्थ्य एउटा सागर सपनाको आश चिन्ता छैन अब टेक्नोलोजीको साथ बिरामीको जीवनमा नयाँ भाग्यको हात इकोसिस्टम फस्टाउँदैछ हाम्रो त्यो नानीता उन्न लचिलो सम्पूर्ण मानव जातिको लागि यो सभ्यता सधैँ
So this one is the last one, Birgans, 100-bedded hospital. So the last image was in Birgans. So multiple projects were there. About 5-6 government and private hospitals were inserted in this clip. For example, in Bardibas, the Bardibas Medical College is 1,200-bedded teaching hospital from the government Ministry of Education. So it was considered as one of the separate 100-bedded trauma center, and then the rest of them is for the the education department, 1,200-bedded teaching hospital. So similarly, the Lumini Provincial Hospital was a multi-speciality hospital, considering oncology and gynecology and the cath lab, cardiology system were introduced over there. So the rest of the hospitals were private hospitals, were in different places, like Advanced International Hospital in Vairava, another Birgans South City Mal Hospital was there, and some of the examples were there. Thank you.
Thank you, Mr. Mahendra Kushal, for your very interesting and very useful discussion and presentations. Now I like to invite Engineer Mahesh Nakarni, Chairman, Health, Environment and Climate Action Federation, HICAF 360, and Chief Technical Specialist for Zero Waste Management System into hospitals. Sir, time is yours.
त्यहाँ बुममै जाँदा हुन्छ नि बुममै जाँदा हुन्छ
Namaste. I'm going to talk about the waste management in hospitals. I think I have a very good opportunity to work closely with National Open College, because when we have started the system, the new system here, I think I have the first intern is from National Open College, which I have done the mentorship for our thesis. I think I forgot her name, she's now in the UK, I think. And then after I have got many students from National Open College as the interns, and we have been closely working with Open College. That's a very good opportunity I have. So HECAF is Health, Environment, Climate Action Commission. It's a non-government organization working on the environmental health basically. So we are the pioneer in South Asia to develop this zero waste system in hospitals. So we work with health and environment and the climate. 3 areas we are working in this field. So we have different goals, mostly focused on the hospitals, the healthcare systems. So wastewater, climate. Now we are working on the climate and healthcare settings. So I think you have seen the previous slides. Previous presenter has said about this climate resilience. The disaster resilience is one of the part of the climate resilience system. So zero waste and healthcare waste management is one of our main activities. So you can see this is a hospital and healthcare waste, hospital waste. You can imagine the situation, yeah. So whatever you build, any big hospitals, any high-risk sufficient hospitals, if you not do waste management, then your hospital is gone. But till now in Nepal, this is not in priority yet, yeah. But you can see there is a hospital and there is a waste. So you are treating a patient in the hospital and you are bringing out that waste out of the hospital and making another patient and taking inviting them to the hospital again. So this is what the scenario is. So to solve this, we have developed zero waste management system. What is zero waste? Zero waste is the conservation of all resources by means of responsible production, consumption, reuse, recovery of products, packaging and materials without burning, and with no discharges to land, water or air that threaten the environment or human health. This is a very challenging definition because you cannot throw it away, you cannot put in the air, put in the water, put in the land. Yeah, so very challenging. So this is the solution we have to find for that. This is what we did. This is what we call a zero waste system. So zero waste system is less waste to landfill. And I know that many of hospitals have done some work on that, but still not the complete work has been done. So there is a hierarchy. Zero waste hierarchy. It's called zero waste hierarchy. You can see. You can see this is the. You can see here like there are the hierarchy, and you can see the traditional hierarchy was more to landfill, everything to throw away. But now the new paradigm is set, and now the less waste to landfill. You can see less waste to landfill is the zero waste now. So that's what. But many instances maybe you can burn and then there is no waste to landfill, but that is wrong. You cannot burn it. So for this we have to have a 4-pillar system. We have the infrastructure, we have the equipment and supplies, we have to have a capacity building, man resource. All these are the major part of the system we have to design. So first of all, we have to design a waste management center. In many hospitals now, still waste is not priority. So there is no waste management unit, there is no waste management center. They just take waste management as the role of the sweeper. That's all. So we have changed that concept, and now we have. This is a design of a. You can see this is a design of the waste management center where you have the whole center is there, where the infectious waste goes, where the treatment goes, and how it come out. So everything is then there is also the waste. Zero waste is not one is one type of waste. In healthcare waste there are another 8-9 types of waste are there, which we have to manage separately. But now still there is a concept of the hospital directors or the actually that the solution is one. That's wrong. There is no one solution for all the type of hospital waste. So we have to find we have already find the solution for each type of waste. So, but like sorry. So this is the whole waste management center. Within every hospital we have to do that, and then you can see there is a system in the world, the waste segregation system, because the main solution of the waste is the waste segregation at source, which we are not doing yet. Yeah, so we have to have a proper system in each room, each ward, and that is we have to have this. We have to have this waste segregation system. We have to have these trolleys, the medical stands, then also we have to have a sharp waste management system. Everything should be integrated in the hospital wards. Then transportation should be separately, both
rigs, hazardous and non-hazardous separately, because in most of the hospitals they separate the ward and they put everything in one trolley and bring to the. That's also not. So another is the treatment. So in the past, treatment is a very difficult task. So ECAF has pioneered the proper waste management system using autoclave. So now we have a more advanced autoclaves called pre-vacuum autoclave with a smart system. So we have developed this, ECAF has developed this. Now we have this autoclave system, which we have this, this is the autoclave, which is a pre-vacuum autoclave, and which it is scientifically tested, the every operation of the autoclave, which will prove that the waste has been disinfected properly. So this is the main thing. So it is also a medical legal case. So in a legal case also, this spore, we put the spore and test if the autoclave is working properly or not. So that's what is our achievement now. Now we have developed autoclave. When the autoclave start at hospital, we will get the message now mobile, that we have developed now. And it's innovation. Under the innovation we have done that. So now we can monitor from here, the hospital from, like we are monitoring from Sethi General Hospital, we are monitoring from other hospital sitting in the room, we can monitor that. This is our innovation. So that means now born to non-born, So this is one important thing is that you can see that we used to born in the incinerator. So even in India, I think all waste is incinerated. Most of the infectious waste is incinerated. And that's why we have a pollution problem there. So this is now totally illegal to burn the waste in Nepal. So we have to have either autoclave or microwave. So the technology has been very advanced to develop on this. Actually, we don't have the autoclave manufacturers, but we autoclave manufacture in India. But under our request, under our advice, they have modified the autoclave now for the waste management. That's what we have achieved now. So this is after the waste treatment and waste management, you will see that all these resources has been collected like this, and this is all the resources now. So hospital is earning money with this thing. So this is what we actually know. This is called zero waste now. So because this waste has been saved from the landfill, we can manage zero waste. Means doesn't mean it goes to zero. It tends to zero. So almost 90% waste we can manage very easily now. What hospitals should be responsible. The hospital has the attitude that, sorry, I am not telling any particular hospital, but in my 25 years experience in this field, I found that hospital is now changing, but slowly. Hospital just wants to give responsibility to others. And they give the example of India. Because India, the hospital doesn't care. The hospital is cared by the common waste treatment facility with the waste taken by them. Hospital is not responsible. But in Nepal, by law, hospital is responsible. But still, it is difficult to them to make convinced that they are responsible. By law, the hospital is responsible. So after this responsibility is taken, you can see this is the waste earned by the hospital is now getting to the money now. This turns to money now. And this is WHO certified, globally certified now. So for the and another major part is the pathological waste. We get the birth, there's the placenta, there's the body part. So we have developed a special type of biodigestion system where we can do the put the placenta and food waste. We have it is a double chamber system where we can generate gas from this. And this is for a solution for the pathological waste, not for every waste, but pathological waste only. Okay. So, but if there is no pathological waste, only food waste, we can also do the composting. Composting only. If there is only the food waste, not the pathological. If there is pathological, we must have the biodigestion system. So you can see now in one of the hospitals, this is data of 2019, we have done assessment. Almost like 92% waste was RIX waste, 8% was non-RIX waste when we did assessment. But that if that system was there, if the proper system was there, that waste could be 33% RIX waste, 67% non-RIX waste. But what happened after we designed the system, we implemented, we found that 34% of the waste is RIX and 60% non-RIX. So almost very close to the assessment data. So this is the result we found, and this is what the successful means. This shows that our system is very successful. So the waste collected is almost like it's a different by sorry. waste collection in hospital is increased by because that time we started this. So the according to the bed, because increase of bed, the waste is increased. So you can see all the waste is collected and by weight, we did the weight. And then we can see that the percentage of recycle. You can see that most of the waste has been sent to recyclers. And then you can see the autoclave waste is also increased. So you can see that there is autoclave waste. And the infectious waste, syringes, metal shaft, all are in all body parts, all the waste which is stuck with the body fluid should be treated as an infectious waste, and we have done autoclave in that. And then income, we can see income is also increased by like that. And you can see the interesting thing is that in hospital, the highest percentage of waste is plastic, which is recyclable. It is sold and it is a part of income. So income of waste is 90% of it is almost from the plastics, because the plastic is high class plastic used in hospitals. So it shows that this is a part of the zero waste and circular economy. So now I would like to show some of the theme, according to the theme of the Together for Health, the role of evidence-based finance in the sustaining health system. Very interesting thing is that we talk about the finance, but we never talk about the finance for the waste management. We talk about the finance for the OT, for the ICU, because that on money, it comes to money easily. But waste is neglected. There is no finance for waste. It's one problem I have seen my experiences. And so they feel that healthcare waste management is viewed as a cost, not as an investment. So now we have been successful in some hospitals to change this attitude, and the directors are very much positively taking it. But those who are not taking it seriously, waste is someone's responsibility, like Maila Dai or Ram Devi, someone in the sweeper side, they take the responsibility. They never take about the management side. So this has been a big challenge in house. And there is a limited financial resource in hospitals, because you have to buy the medical equipment every year, you have to change the MRI, you have to change the CT scan, but you never think of doing anything for the waste management. This is a very pity situation in Nepal, but we have been changing that. So awareness is, because lack of awareness is there. No, they have awareness, but it's not effective awareness they have. Why the waste management is important for the hospital. They don't see the result. They will see the result after maybe some years, but they will not see the result now. So, and also there is a weak regulatory enforcement, because the government is very weak in doing the enforcement. And whenever they do the strict enforcement, they all come to us then. Oh, Mahasi, can you help me? I have been fined for 1 lakh rupees. Please can. Then they come to us and ask for the help. But this is not the way to do it, because its priority is given. Now the government is going to be very tight in this aspect, and so the enforcement will be very strict. So then before doing that, getting fined about that, we have to be serious about it. I feel that there is also not adequate knowledge on the hospital waste management, because there are different systems around the world. Most of them are burning, because many of the other countries are burning waste. And but now, due to climate, due to the global systems, burning is minimizing every country, and so that's why we have to understand that there are a lot of technologies also there. Now we have the microwave, we have the autoclaving, non-burn technologies are there. So I think there is not so much problem about technologies. So now the solution is only circular economy to zero waste. That's the only solution we keep thinking. And also there is no priority in the initial capital cost, because waste management is initial capital cost. Something like you have to build a small house for the waste management center, you have to buy the equipment, but that is the no priority at the moment. But I'm very happy to say that any government hospital is approaching to the government is always positive to do waste management as a first priority. I've been working to many hospitals where the hospital has requested to government and government has given the proper money to do the system for the hospitals. But the hospitals should be active on that. And I always say, perception is that waste management is someone's responsibility. So they just rely on the people who buy the waste, who come and collect the waste. They are rely on this, and they say, "Oh, our waste is taken care by someone. We are happy. Nothing, no problem." We have seen that in the COVID time. Then they were crying. Yeah. So that's what. So another problem is that there is a leadership problem and also the accountability problem also there. So now I think things are changing because many hospitals are now coming to this point, and government is also making this as there's a rule already government has made. So this is the recognition we got from the president of Zero Waste USA, Ms. Ruth Abbey, who visited here, and she has said that Zero Waste USA has been part of the delegation visiting Zero Waste hospitals in Nepal. Ekapcha City has created a visionary and revolutionary approach to collection of medical waste, management of medical waste resources through a zero waste lens. We have visited zero waste models all over the world. Observed that Ekapcha City is a true leaders in medical waste management at the hospitals. This is one of our who have authorized, who have given us this recognition.
Hello everyone, my name is Paul Mortensen. I'm on the board for Zero Waste International and promote zero waste all over the world. When I visited Nepal in Kathmandu and took a room tour with HECAF, which is the Health, Environment and Climate Action Foundation, Mr. Mahesh was leading it. He took me to 2 hospitals that showed me incredible work that HECAF had been doing. And it was about hospital waste management. We all know how challenging hospital waste is. There are many different waste streams, infectious materials, hazardous chemicals, and sharp and toxic waste, of course, that must be handled in a safe and professional way to protect both people and the environment. What I saw was truly impressed. This is not just about managing waste, it's about creating a culture of responsibility, sustainability, and respect both human health and the nature. The system is practical, easy to understand, and simple to implement, yet the results are remarkable. I would describe it as genuine zero waste thinking in action. It is smart, intelligent, efficient, and in my opinion, absolutely world class. These hospitals are amazing. I have visited many places and looked at different zero waste projects around the world, and I can honestly say that what I have seen in Kathmandu deserves international recognition. It is an inspiring example of how innovative solutions do not have to be complicated. Sometimes the best ideas are the simplest ones. My sincere thank you to Mr. Mahesh for his kindness of sharing his knowledge and all the incredible job he's been doing in Kathmandu, and for giving me this opportunity to go around and look. So thank you very much, and I wish you all a very good day. Thank you very much.
Yeah, we have been working in other countries also. We have done some work in Bhutan, Sri Lanka, and Bangladesh, Cox's Bazar, the refugee camp. We have done the Western system. Also now the latest one is Laos. Last year we completed with WHO, Laos. So we have been partnering with WHO. And after this, my revision of our work in Nepal, the Zero Waste International Alliance has been nominated me as the board of directors of Zero Waste International Alliance. So we are taking this all over the world. But it's difficult to work in Nepal rather than working outside. But outside they understand very well Nepal is very difficult and means why it is important. That's my painful story about it. I spent all my 25 to 26 years on this, so I am the pioneer of this. But I am very much happy that I am bringing more young professionals on this by training them. I see one of is here, one is here. My intern is here. So, yeah. So I think we have now many young people are coming up. So I think it will be very good to make Nepal more cleaner, Nepal hospital more cleaner. If you invest in the waste management, you will get a very much good reward in the future because your hospital will be clean, your hospital will be visited by many people like that. So that we have to understand. So thank you very much.
Thank you, Engineer Moish Nakardi, for your delightful presentations. And as you have mentioned that one of the hardest country, Nepal, the rest of the country is much easier to practice and implement. But when we start implementing, we will never forget in our life. So Nepal will be always there, and young generation of healthcare manager will lead and support your project, Zero Waste Management. Thank you once again for your presentations. Now, it will be my great honor and privilege to invite Major General Professor Dr. Puneet Yadav, Dean Academics and Student Affairs, IIHMR, MD Hospital Administration, MBBS for your keynote paper. And Professor Puneet, we are very much delighted and happy to be part of your organizations, and as we have discussed in the morning also, so we will be welcoming you for your keynote paper. Thank you.
So good evening everyone, and it's been a great pleasure to come to Nepal, Kathmandu. It was a great honor being invited by National Nepal Open College out here, and I look forward to partnership with IIHMR Delhi, and we look forward to going forward in multi-dimensional route of academics, training, research, consultancy. So that's a wonderful road ahead that we can look ahead to. And in this perspective, you all welcome to Delhi anytime. You are all welcome to IIHMR Delhi whenever you come there. So it will be a great pleasure to actually host you. Today's talk came to my thought was basically started with evidence-based finance, and how do we relate it to the hospital operations. The aspects which right. So when I was looking at this topic of relating evidence-based finance to hospital operational management, it came to my thought that there are many case studies and examples that we actually set out. And when we look at management per se, we always refer to management as an art and a science. What we have listened to some very eminent speakers right from the morning itself, or in various areas of research that they have conducted, in various areas that they have worked on, be it hospital waste management, be it hospital facility planning, be it in fundamental public health aspects and so on, human resource management, so all that. So what is art? Art is nothing, you're all young leaders sitting out here in the hospital healthcare management systems. You all will be taking your steps to the professional world, and many of you are actually working there. So what is the art of management? The art of management is nothing but a collation that as a leader that you can take on all these points which have been put forth by these by the eminent speakers out here, and construct them into a one whole and bring it to the best practices across to the table. So that's the art of it. But then what is our challenge? So that's what came to my mind. Both India and Nepal, we are low middle income countries as far as world is concerned. So, and at the same time, how do we look at hospital operations management in the light of resource constraints that we have in our systems out here? And resource constraints can be a multi-level resource constraint. And what are the answers that as hospital care management experts that we can actually bring to the table? So this was what was, I came across a very interesting article, and this interesting article was when I was given this topic and I was thinking about it. So this article referred to as the challenges are not just organizational but also clinical. So in the morning the speakers had mentioned that yes, there is a clinical domain, but there's also a management domain to that fact. And this article very aptly actually brings out that today the management, what we have today, we got conflicting missions and prioritization as far as, especially in the countries that we live in. And when we look at conflicting missions and prioritization is providing the necessary access to healthcare as a human right or as human dignity in our health systems with the financial constraints that actually we have. And that is where there is always a conflict both in India and maybe in Nepal, but definitely in India, between the public health systems and the private health systems out there. So we've got laws which are coming in where certain beds are to be reserved for the lower income group people, but at the same time there are always conflicts regarding whether the utilization of those particular beds also. So that's one aspect that we are looking at, conflicting missions and prioritization. Also, where do we actually focus our areas on? Do we focus on communicable diseases or do we focus on NCDs out here? Because that's another problem that is gaining hand as far as we are both living in a world or living in a country that has got communicable disease problem as well as non-communicable disease problem, and then where do the investments actually go to? So that's the second part of it. The second thing is workforce requirements. Now, we got large population with us out here, but at the same time, do they have the skill sets to actually transform healthcare? There has been a lot of focus on in the last few years, which has been on development of human resources. But there is a definite gap wherein it comes to skilling. Now, when it comes down to skilling, whether the person, when he passes out of an educational institution or a training institution, whether they will be able to step forward and start working from day one in the industry. I mean, morning, Dr. Sutapa, the director, spoke about the national education policy. So that's what we have come to in India, is they are striving out that the colleges re-engineer themselves in a manner that the students who come out from there are industry ready as far as they are concerned. So that's another challenge that we are facing. The third is the demanding health environment. Healthcare is a very, very demanding world. Being in healthcare is extremely demanding. It is a 24/7 kind of a industry which is always looking at things. The health outcomes are of very severe nature, because ultimately it is not only affecting individuals, it is affecting families. So that's a very, very important way in which. So the government also looks at it very, very closely. The next thing is complex day-to-day task environments. So like I mentioned, 24/7, and every day you have operating theatres, you have intensive care units, you have the biomedical waste management going on somewhere. So the complexity of day-to-day environment as far as the leadership is concerned is amazing. As far as the healthcare industry is one of the most complex industries to actually lead. This can be achieved through organizational learning, and that is what we are here for. Shared learning is a thing that should be there in all healthcare colleges, training institutes, so that we take our initiatives forward and look at effective management practices. So that's where we are looking at. But when I consider all these system challenges, I'm talking of resource constraints. and I'm talking of my deficiencies as far as we are concerned, that we have not been able to achieve what the West has achieved. But is the West there? Is the West where we are? The West has its own challenges. They have got a very high income tax rate, which obviously we cannot put it on our population. But their access to healthcare systems, they've got long waiting times. So the money is fundamentally not the real answer, that you pour in money and the systems will give it. US is spending 15% of the GDP, UK is spending 10% of the GDP. We are like Nepal, we are spending 2.5% of the GDP out here, right? But what about the access to healthcare systems out here? So that's one important facet of it that we actually have to look at. There's a large amount of inequity as far as the US is concerned. In OECD countries, which are usually have the social insurance and all that, the equity is there, but again the access is limited. So there are two answers that we, in our country, with both the Western philosophy and Eastern philosophy, we can't just pick up the Western philosophy and put it into our systems. We have to look at our own kind of ways and means in which to go forward. So that's what we have to look at. Looking at the key management, I always tell my students, when it comes down to health outcomes, please do not look at health outcomes only in terms of finances. There are two health outcomes which are always coming up. One is your business outcomes, if you are in a private sector. If you are in a public sector, then also these financial outcomes matter, because ultimately it is about utilizing the budget to the best way possible. And the second is patient outcomes. Patient outcomes are equally important as far as we are concerned. So when it is measured, when any system is measured, it has to be measured in terms of two outcomes, the financial outcomes as well as the patient outcomes. And when it looks at, when you are looking at efficient processes, time, cost and quality. These are the fundamental aspects on which we look at operations management. I'll be looking at some case studies as I go forward out here. So, but essentially, when I look at resource management, processes, you are looking at patient delivery, you are looking at human resource, you are looking at materials, financial resources, we are looking at facility management, and we are looking at information system. Today, largely one can look at that information system is also a resource. Information system is a resource. We need to consider information systems because it brings in efficiencies as far as the system is concerned. So that's where, when we look at our system, we look at our system holistically in this kind of a manner out here. I'll spend slightly more time on the issues which are there. So once we have addressed the management challenges that we are looking at, let us look at how do we manage it from a hospital operations perspective out here. Managing these resource constraints. The first is using tools and techniques. Remember, we are all students of healthcare management. And when we are students of healthcare management, we require to recognize that we require to develop analytical abilities with us in all aspects of hospital management. And we'll look at some of the tools that we are looking at. The second is that we have to look at evidence-based research. Research is something which you can take forward to learnings in academics. So we have to invest in research. Today, when we always talk of AI, but when we are talking of AI, where are the AI models being trained on? Ultimately, it is the data that the AI model is training on. And where is the data coming from? Is it coming from specific studies which have been conducted in European countries? Then is it applicable to our country as far as we are concerned, or our neighborhood, or our the Southeastern, or even the Asian region? So a AI model developed on a data which is there in the European or the US context may not be applicable to an Asian context. So this is something that we must remember. So that's why evidence-based research is important. Leadership, I'll come to that leadership because leadership provides the necessary. We had a wonderful talk on leadership regarding how human resource development actually comes to the fore regarding the eye hospital out there. But that's what leadership is all about. That's how we have to lead the complete this. Then culture becomes important. Culture becomes very important. Can we put in the philosophy, or we have to imbibe our own culture, and that is where we have to build up, and innovation. So these are things which we actually talk about. The first aspect that we look at is these are the management tools and techniques that we utilize as far as hospital operations management is concerned. We looked at various things. One is infrastructure. Now infrastructure, developing flowcharts, developing interrelationship models, developing PERT and CPM models. So I'll give you an illustration of this wherein what we had applied and how could we change cost through evidence-based practice. So that's something which we recognize. I'll just come to a slide. Slideshow. Yeah. So this was a brownfield hospital project which I am actually coming to. And the brownfield hospital project was a medical college. And what happened was the initial project cost was approved for approximately 300 crores. It went into, we plan, we'll do this, we'll do that, and all that thing. The cost got revised upwards. The cost got revised first to 500, then to 700. When the project went back to the government said, what are you doing? For the last 7 years, this medical college is in a kind of a state where you are not, we have given sanctions and you are not progressing. So a management team was constituted. We came into the picture somewhere in 2010-11. We came into the picture and we decided to apply operational management techniques out there. So the first thing is when we drew up the plans, we looked at interrelationships through Luther's grid, through using complete systems, automated systems out there to plan the system out there. And therein, the project costs dipped from 700 crores to 600 crores. So that's the first element that when we went to the government, the cost had come down from 700 to 600 because we had used these facility planning. We had used Muther's grid for interrelationship design, and because we used that, the necessary services that were there, the engineering services that cost came down. So it came down to 600 odd crores. We developed the PERT CPM out there. We went to the government again asked us what is the timeline. They told us we told them 4 years out there. So they said we are not going to give you any more money. This is sanctioned, so ultimately the project was sanctioned for 600 crores. The hospital started coming up and we came in, we developed the PERT and CPM which is there. We looked at the slacks, we cut down on the slacks, and ultimately we collapsed the project. The project came on in 3 years, 6 months before time, with a project savings of 60 crores. So in effect, when we actually started from 700 out there, by utilizing the operational management techniques, we had a saving of 100. So that is one of the illustrations when we are doing facility design planning. That is something that we actually have to take forward. The second thing is this a little bit of a I'm still on the project side, which is from primary health care centers right up to the tertiary health care centers. there's still a fascination about closed buildings and all that thing. Does our culture really need closed buildings in primary health sector setups, where the population is coming from rural backgrounds? They are living in a world which is really close to nature, environment out there. So there was this project which was conceived in Gujarat, which was a primary healthcare center project, where they used local materials to build a primary health centers as per the architectural norms. And that resulted again in a cost saving of about 10 to 15 crores for the state government out here. So this is where we need to apply ourselves out here to take forward these initiatives, to apply these techniques to actually come forth on these guidelines. I'll go back to that slide again. This was that Muther's grid, just an activity. Right. The second example regarding human resource management. Now again, human resource management, if you look at the staffing, can you staff by using aggregate planning methods based on your workloads? This is a question which can be asked based on your ICU workload. I don't know whether you have heard of the TIS 24 scoring or the NEMS scoring, which is done for nursing requirements for critical care patients. Now when you look at nursing requirements for critical care patients, and now that is based on the functional level scores itself, which are there. That is a very flexi kind of an arrangement for nursing, which is actually got built up. Now this was another study which was done. This was in a corporate hospital which had been done. And when they did a nurse activity sampling, which is there, they found that actually the percentage of time which was spent in documentation was enormously high. So is it that our systems of accreditation, NABH and such, are overloading the nursing staff to an extent that they are not able to spend time with patients? That's a question that we as managers require to ask out here in the management field. And how can we reduce the workload for documentation and the administrative workload for the nursing staff who are in direct and indirect care of patients? So this was again a study which was done in one of the corporate hospitals, where they found an enormously high time being spent by nurses just in filling the documentations and writing registers. So that's another. The answer to that ultimately was that patient-focused designs by implementing flexi systems out here, wherein the nurse should be able to spend much more time with the patient out here, improving the quality of patient outcomes, reduce the documentation, take out all unnecessary documentation which really do not impact the patient care processes and the business processes. Ultimately, when they found the nurses who were filling up the form, they found 50% of the documentation was such which could have been done away with. It's just that many new managers coming in and adding the AV report, give me this report also, give me this report also. So ultimately, over a period of time, the nurse was filling a large amount of reports and nobody was taking off the reports. So that's something that we require to redesign the systems. Also, administrative task load reduction. We don't want our patient care processes to be affected by administrative workloads. So mechanisms for reducing the administrative workloads require to be taken into account on this field itself. One of the examples in hospitals was that instead of the nurse sending an indent to the making an indent, sending it to the pharmacy sending it back. The nurses again looking at the form, what is to be coming the ward, is a push system, whereupon the pharmacy was sending a load across to straight away load across to the ward itself, where the nurse did not have the necessary, did not have to spend the time in making indents and all those kind of things. It was just the items were being pushed in by the pharmacy rather than the pull-in system which is there. So again, it results in a lot of time savings and cost savings as far as inventory is concerned. So that's another one. Next slide. Another aspect which actually comes into play when it comes down to looking at is scheduling systems and waiting line systems. Now this was again a medical college. Now you see the wait on the waiting time. The blue line, straight line, is the number of patients which are on an average which are arriving in the hospital. Again, a very busy medical college hospital. And the patients in the dotted blue line are who were being serviced by the doctors. But ultimately, somewhere around 10:30, you will find the queue had built up to an extent that there were almost 300 or 400 odd patients who were waiting in various departments across the whole hospital with a waiting time of almost 2.5 hours or 3 hours. So how do we reduce that? That is another aspect, because ultimately waiting time is also cost. Time is also cost, that must be remembered. The patient who actually waits for 3 hours out here may be coming next day again and putting in a line. There is a lot of movement which actually came, so time is also cost. So when it comes down to cost, we need to look at service counters. We need to look at multi-level task workers. We need to look at referral and trial systems and bring in efficiencies, not the NHS kind, but our way forward out here. Staffing alignment and automation. Automation is coming in a very big way. I'll be talking about automation also. So that's another aspect that we look at. The next issue, another operational research technique that we used in one of our hospitals was flow process management. Now these are all analytical techniques which the young people sitting, the students need to imbibe and actually start working out there, because these are techniques which give them a perspective about how processes can be actually be improved. And these were the typical head injury cases where we were looking at door to scan time. So that is how we are looking at. And we measured each and every activity out here, divided into 5 different zones of right from what is the actual operations, patient handling which are there, transporting from one place to another place, any delays which were happening, any inspections which were happening. So this we mapped out each and every activity as such on this flow process chart, and ultimately we found where the activities can be done away with. Some activities which we can be done away with, and as a result of which the time, the initial time was 67 minutes. Ultimately it had come down to 45 minutes because of reduction of those timelines. So these are some of the techniques which were again applied there. And thereafter there was another operational research techniques and quality techniques that we have been using. There are a large number of quality control techniques which have resulted in reduction in costs as well as reduction in the time for patient processing, better throughput as far as the patients are concerned, because we require a larger number of patients actually coming in. So these were the run and control charts where we had processed the patients out there. There was a drop in the number of patients. We had to make interventions because in the accident and emergency and in the OPD counters, manage complete processes out here, redesign the processes, and because of the reduction, the income, the confidence of the population had come down. The total number of patients in the hospital had come down, the revenues were falling in, the complete processes were redesigned, the OPDs were redesigned into appointment systems, into priority systems, and such systems, the scheduling system were redesigned, ultimately which brought back the patients which were there out here. So that is some aspects that we are actually dealing with when we are dealing with quality systems out here. And this was one interesting study that actually we done. and this was again costing, this was to come to us regarding costing. How do you cost in the education of a medical graduate? So it is, some may say, okay, he's coming out here, these are the education costs, right? But when you look at a medical college, when a student is actually coming to a medical college, it is not just the faculty education. The faculty is also treating the patients. The faculty is also teaching the postgraduates. So how much cost do you apportion to the graduate education? How much cost do you apportion to the postgraduate education? How much cost do you apportion to the patient care? That one faculty who may be earning 1.5 lakhs or 2 lakhs, how much of that share can you apportion to the graduate education? That's a big questions as far as we are concerned. And that has to be looked at. So this was again a study which we did historical costing, activity-based costing. And this costing was done in 2000. And why it became interesting was because what we have shared concerns is the brain drain, which is happening from colleges, particularly the medical graduates, the paramedical graduates, who are going to the Western countries and getting education practically free of cost in the government hospitals or medical colleges and then going out there. So we came out to a figure of 15 lakhs, which was there. It went to the government accepted this figure once we had given evidence-based presentations, where they accepted this figure and they came out with a policy framework where for the central government started looking at that either you serve the community health centers or in any government organization for a period of 3 to 5 years, depending on that organization, or if you want to leave, you need to pay back 15 lakh rupees. So that was something which got built up because of this costing exercise that we had actually conducted for the government itself. So Ahmed, when we look at the importance of hospital operations, we are looking at all these issues which are there, which are these tools and techniques that we are actually utilizing out here for looking at saving time, costs and improving the quality, so that we are into a better position as far as the hospitals are concerned. And that's where resource management comes into play. The next issue, I was talking of research, and morning Dr. Sudappa was here. We are carrying out an evidence-based Indian Council of Medical Research project, which is being done. It is on stillbirth, which is in one of the districts in Unnao. And what we are doing there is, it is as a public-private partnership model. We are the academic knowledge partners for the ICMR and for the state government of Uttar Pradesh. So this is being there to implement healthcare quality systems to reduce the stillbirth rates in some districts in the state of UP. That project is ongoing. But the important part is, without local participation, it is not possible to achieve our health outcomes. So local participation, community engagement becomes a very, very important parameter when it comes down to managing resources in our countries as we look at it. So unless and until acceptability is there for the local participation, it's not feasible for us to actually implement a quality system out here. Leadership, I was talking of, is another aspect. I don't know whether you have heard of Narayana Health Philosophy by Dr. Devi Shetty. Dr. Devi Shetty, cardiothoracic surgeon, started his hospital in Bangalore, and his vision was to provide low-cost care for surgeries and for such complicated operations for the Indian population. And his model is made from volumes, which is there, wherein you go to his Narayana Health in Bangalore and you'll find a 200 bedded ICU out there. So his model works on quantity, bringing out the necessary outcomes out here, which is important for countries like us. He's built an insurance model of that you pay 50 rupees and you can undertake 50 different surgeries which are there in the state of Karnataka. So is this the answer? When we are looking at resource constraints environments, we were looking at health insurance in the morning, lot of talk. Is this the answer to our problem of resource constraints or financial constraints? So that's another aspect that we require to look at, but necessarily leadership therein becomes an important element. Coming to culture, respecting culture in health systems becomes important, because in like I was talking of primary health center in the state of Gujarat, making it friendly for them to actually come there. And interestingly, there was the Parsis. They were earlier very, as a community, they were very close-knit communities, and close to, of course, though they are in Mumbai and the western part of India, but they are very open to going to environments, and they love environments, flowers, gardens and all that thing. So when Wadia Institute of Cardiology was building the hospital, there's a special request from the community that you should have one ward with a garden and bougainvillea. They call it now the bougainvillea ward, because most of these people, they come there and they like to be treated there in an environment out here. Recently, if you see UK, one of the hospitals there, they made an ICU which has got an environment, which has got a garden which is actually built in out there with a very open sky and a glass facade out here. So are we coming back to a system wherein you are looking at nightingale wards and open wards? Because ultimately it is about nature. So that's where when we talked of closed confines, air conditioning and all those kind of things, now are we coming back to our roots again? So that's something where we have to look at our culture and all these aspects. And digital innovation is something, there's a small little where we actually looked at costs, how do we save costs, was bringing in barcoding, and we had brought it, it was again a 700 bedded hospital. We built in barcodes for the inventory, and we had primary, secondary and tertiary barcodes. Primary was for the strip, secondary was for the small pack, and the tertiary one was for the large. And we asked the vendors to get it and put it there and bring it. It resulted in massive number of inventories, cost savings as far as we are concerned. The hospital gained almost as much as 15% of the budgeted savings, because your inventory could be tracked, the right medicines were reaching to the right patients out here, and ultimately the obsolescence of medicines and the expiry of medicines got reduced significantly, because the complete tracking mechanisms was, the track and trace mechanism was present. So that's how we actually went from cultural innovations. In conclusion, healthcare leadership, particularly in countries like ours, is a high-stake balancing act. And when I look at high-stake balancing act, you have to look at your own community healthcare requirements, balance it with your financial, your human resource and your materials requirements, and of course, lean operations, frugal digital innovations, and demand side measures addressing them become an important paradigm to have a successful and meeting these challenges in this resource constraints. So that's my little thought for the day. The subject is vast, but hopefully we all together can take this initiative forward, and together these innovative frugal in digital innovations or other innovations forward in together, so that we can reach a stage where we can proudly say that because of our interventions the health care management scenario in our country has. Thank you.
Thank you, Major General Professor Dr. Puneet Yadav, for your delightful, insightful keynote papers. At the end, I would like to really appreciate and thank National Open College for allowing me to be a chair for the second sessions. Thank you so much, and I really appreciate all the presenters who have presented in second session as the topic of hospital management. It was really interesting. After a lunch, appreciated Mr. Sudhir as being a first graduate from National Open College, started a hospitals in the ICE, hospitals in Lan and Viratnagar, and doing a tremendous work, and in the field of human resource, also improving human resources and making everyone work on the side of ICE. And Engineer Kapil, Professor Engineer Kapil, thank you for your delightful insight talks is voice management in Nepal, and that was very useful. Dr. Sunil Shrestha Sinaj, rethinking patient safety from the top, the clinical pharmacist's role in reducing medication error in Nepal, putting more thoughts regarding the medications and parameters. At the same time, other graduates, Mr. Mahendra Bhushal, we have talked about hospital designs, future-proofing healthcare systems. And another one major topic was zero hospital waste management, which was presented by Engineer Mahesh Nakarmisa, and it was really insightful. And at the last, the keynote speaker was Major General Professor Dr. Puneet about hospital operation management challenges in resource constraint settings. And I apologize due to the time constraint. We are not going to have a discussion sessions, but I will promise you during the break time, tea time, we'll have a discussion. If you have any concerns, we all are will be present there. All the speakers will be there. You can discuss at any time. And thank you so much for cooperating for session 2. Thank you.
Ladies and gentlemen, we now come to the closing session of today's program. For the chair of session, we have Professor Dr. Sital Kumar Karki, PhD founder, advisor of NOC. So may I please invite you to come for the closing remarks. May I respectfully invite Dr. Manoj Humagai, Dean of Kathmandu University, School of Medical Science, as a chief guest for this session and address the closing ceremony. As a small gesture of appreciation and respect, we will now like to present the token of love and distribution of certificate to our respected guests and presenters today. As I call the name, may I kindly invite our distinguished guests and presenters to come forward and receive the token of love. Let's give them a round of applause as we present the expression of gratitude. Without further ado, I would like to invite Professor R.P. Panjiar sir to receive the token of love. Sir, can we have you on the stage, please? And for that, I would like to request our chief guest for this session. Moving forward, I would like to request our chief guest, Director IIHMR, Professor Dr. Sutapa Niyogi. Ma'am, can you please come up on the stage to receive the guest? receive the token of law. Can we please give them a round of applause? Thank you, ma'am. Moving forward, can we please have Professor Dr. P.N. Aryal, ex-VC, Pokhara University. Okay, moving forward, can we please have Professor Dr. Anjan Kumar Mishra, Dean of Modest University. Sir, can we please have you on the stage, please? Likewise, I would also like to welcome Mr. Dayaram Thapa, Chairman of National Open College, to come up on the stage. Likewise, I would also like to invite Professor Dr. Tej Kumar Karki, PhD in Urban Planning. Okay. Moving forward, may I request Dr. Yagya Tinusina, MHCM MBBS NOC graduate, to come up on the stage. Moving forward, may I request Dr. Ram Thapa, MHCM MBBS Health Insurance Board of Nepal NOC graduate. So, can we please have you on the stage to receive the token of law? May I now request Professor Dr. Ang Siring Serpa, MHCM MPhil MBBS, Rapti Academy of Health Science and graduate. Ma'am, can we please have you on the stage? Likewise, I would also like to invite Mr. Milan Gurung, CEO, Neuro Hospital Kathmandu, MHCM, BHM graduate of NOC. So, can we please have you on the stage, please? Likewise, I would like to invite Professor Dr. T.K. Gupta, MD-ZP, MBA Health, Faculty of NOC. So, can we please have you on the stage? Likewise, I would like to invite Ms. Swetcha Ranjit, MHCM BPS NOC student, for the token of law. Moving forward, I would like to call Ms. Bethan Morrison. Moving forward, I would like to call Professor Dr. Nidhi Yadav, Associate Professor, IIHMR, PhD in Hospital Management. Ma'am, can you please have you on the stage? Likewise, I would like to invite Mr. Sudhir Thakur, MHCM, BHCM graduate of NOC, Chief Director, NNJS LAN Eye and Ear Care System. So, can you please have you on the stage? Likewise, I would like to invite our next guest, Professor Engineer Kapil Gautam, MSCM, PGD-HCM, graduate of NOC, Faculty of NOC, and CEO of Nepal Cancer Hospital. So, can we please have you on the stage? Next, we have Dr. Sunil Shrestha, PhD Pharmacy, Research Scientist and Senior Clinical Pharmacist. Can we please have you on the stage? Likewise, I would like to invite Mr. Mohendra Bhusal, MHCM, BHCM graduate of NOC, Managing Director, Healthcare International Consult Private Limited. Likewise, I would like to invite Engineer Mahesh Nakarni, Chairman, Health, Environment and Climate Action Foundation, Chief Technical Specialist. Sir, can you please have you on the stage? Moving forward, can we please invite our next guest, a retired Major General Professor, Dr. Puneet Yadav, Dean Academics and Student Affairs, IISMR, MD Hospital Administration and DBS. Can we please have a round of applause one more time? One more time, I'd like to invite Engineer Mahesh Nakarni, Chairman, Health, Environment and Climate Action Foundation, Chief Technical Specialist. Now may I invite Mr. Sangam Doskarki, Director, National Open College, to come up on the stage and have a few words for today's closing ceremony.
Good evening, everyone. Thank you so much for being here. Actually, I don't have much to say, but I'm going to quote from someone very special. This is a message from Professor Dr. Ashok Kumar Agrawal. He's from IHR Delhi, and one of the establishers, very well-established professor from there. So he had a message for this session. So, and I quote, long back in 1977 and 78, the WHO had announced the laudable goals for achieving health for all, and the NRR 1 by 2080. The countries in the Southeast Asia, including Nepal and India, have done significant work towards achieving these goals. However, the challenges remain. The main challenges are in the area of maternal and child health. The maternal, neonatal and infant mortality have to further come down considerably. Besides the malnutrition, stunting, availability of the safe drinking water, sanitation, the school health, etc., need priority attention. The health management per se in these countries should also focus more on skill-based training, supportive supervision, and accountability among the district, regional level health administration. Administrators, system approach, supply chain management, immunization and nutrition. I'm sure this conference will enrich the delegates appropriately so that they are empowered to discharge their responsibilities effectively and efficiently. I'm also sure that the MOU with IHMR Delhi will be beneficial to both the institutes in myriad and numerous ways. I would like to place on record my best wishes for a very successful national seminar and workshop on healthcare management. So the workshop on healthcare management will be held tomorrow at National Open College from 4 p.m. to 8 p.m. So we'll be talking about both hospital operations management and as well as community health management, and both of the series will be led by retired Minister General Professor Dr. Puneet Yadav and Dr. Nidhi Yadav from IHMR Delhi. Thank you so much.
Now, may I respectfully invite Dr. Manoj Magai, Dean of Kathmandu University of Medical Science, our chief guest for our closing session. Sir, can you please come forward and address the closing session?
Thank you very much. Respected Professor Sital Kumar Karki, the founder and advisor of NOC, organizing committee of this 13th National Seminar and Workshop, eminent speakers both from the country and the abroad, and the delegates. Good evening to you all. I'm very happy to be here, to be the part of this very important session today, and I'm very much thankful to Professor Puneet Yadav for his very insightful presentations on the highly needed topic, in fact. Running a hospital, operating a medical college, establishing an institute is not only the purpose. The purpose is beyond that. Serving the humankind, giving the efficient healthcare service to our consumers, that is the people of our community, at the topmost level at a very affordable cost. That's the need, that's the challenge that can be covered through various initiatives. And today's seminar has covered all those aspects. It has covered the health insurance policies. Probably Dr. Ram Thapa has talked about the lacunae and failures of this policy of the government of Nepal, and the forum may have come up with the suggestions to overcome those lacunae. Problem could be there, but running away from the problem is not the solution. The leaders should think about it. Yes, health insurance policy of our country is very, very essential, because most of our people cannot pay from the pocket. But the government should not run away from its responsibilities at the same time. Government should not also be in the loss. So there should be some appropriate way to find it out, and the seminars and conferences and experts' opinions in these forums could give some suggestions to the policymakers, and they could come up with a problem, solutions to those problems. We could have a hospital with a very efficient surgeons or a practitioner. There could be a highly dedicated paramedics, but managing them, integrating them should be done by the efficient managers and student institutes. And I'm very thankful to National Open College for initiating this, initiating a very novel course which is highly needed that is the healthcare management course. I think National Open College is the pioneer college in initiating this, and I would like to congratulate the college management team for this initiative, because you are doing something, you are contributing to the country that is highly needed. Professor Puneet, I am very more thankful to you for your presentation, because Kathmandu University is planning to establish 450 bedded hospital soon. We are doing due diligence, and the matter of finance is a big issue. ADB is funding for it. ADB due diligence team is saying that it costs almost 500 crore, and we are planning to build up in 250 crore. I think that your Muthar's grid will be applicable here as well, and we must be working into it. And I might contact you for this, because your expert opinion will be a guiding for Kathmandu University as well. And whenever needed, I will knock your door. Please accept, don't take that as a disturbance. Please accept it as your compliment to the betterment of the healthcare facility in the country. At the same time, you have highlighted about the Narayana Health Center. That is really a role model of this whole Southeast Asia, where a financial constraint situation also we can provide a quality healthcare service at an affordable cost to our community, and that model is really, really wonderful. And I have heard that he has built up 1,000 bedded hospital within 6 months time period, if I am not wrong. Dr. Sethi has done that. So if those things can be done, why not in Nepal? We must think about it, we must focus about it. We do have plenty of seminars, conferences, workshops. The goals could be achieved if the consensus, if the presentations, we could carry over that to the home and implement it in our practice later. So I believe this seminar workshop will be highly fruitful. It will uplift the overall healthcare facility of the country, and the mission of National Open College to provide the best of best healthcare managers in the country will be successful in the day ahead. I wish the grand success of the program as well as the best wishes to the National Open College. Thank you very much.
As a small gesture of our appreciation and respect, we will now like to present a token of love to our chief guest. May I please request Dr. Sital Karti sir to hand over the token of love to our respected chief guest. Now for the chair of session, we have Professor Dr. Sital Kumar Karti sir. So, may I invite you to come to the stage for the closing remarks.
Thank you very much. So, respected chief guest of the closing session, Dean of Medical Science from Kathmandu University, we are very much thankful for your inspiration, for your encouragement, and for your guidance as well. So, I certainly thank all the chairs of the sessions, our guest and chief guest in the inaugural sessions. I also like to thank all paper presenter, rapporteurs, the organizing committee, this hotel, as well as very most important, the participant. Though participant has been decreased after lunch so much, right? We're so many in the morning. But I'll take an opportunity first to present some resolution for your approval from the floor. There are only 4 resolutions we are proposing in this seminar. So please give your hand when you have the support on that. This is written in a small letter, so I will try to read out. The first resolution is expansion of academic programs. We highly urge the government universities to start bachelor's, master and PhD program in healthcare management as soon as possible. Wish to explain much because it has been 27 years that private sector has taken this responsibility, and we have a lot of struggle. To remind you, until 2017 government did not recognize our graduates in the government position. Only since 2017 they had been employment in the government sector. So you can imagine how much big pain was there to the private sector. So I certainly wish the government will be very fast, sooner will take up these courses in government universities. Next is, so again I need somebody here. This is brown, right? So very small letter, so I cannot read everything. Another is mandatory professional staffing. Regarding the mandatory professional staffing, there has been one meeting to accredit hospitals in Nepal in the cooperation of WHO back in 2003, and our college has one representative in WHO committee to accredit the hospital in 2003, 4, up to 6, and that has disappeared now. You see, as for that, if you have 50 bed or more, you must have a full-time healthcare managers who have a graduation from the recognized degree. So that should be mandatory, in my opinion, for private as well as for the government sector. If they are 50 bed, let's say start with 50 bed or above hospital, they must have a full-time graduation. Do you agree? Third one is, there should be always collaboration. You see, we are talking long time, we are talking about private-public partnership, but it's just a talking, yeah? We are not doing actually that. So, in this time, we have to form not only government and private, but with the global institution, particularly with India, we have to be collaboration in the field of healthcare management. Otherwise, we will not reach our destination, and our 2.6% of GDP will not be able to support the healthcare system in Nepal. We need a lot of collaboration with Indian institutions and share their experience. That's why we are having the So that's why we are having the MOU with CMC Vellore as well as IISMR. In the long time, since 2004, we are collaborating with AIMS also. Our student has been placed in internship for in AIMS also. So a lot of students have done internship for 1 month in AIMS, right? So last one, the fourth one. Oh, that is another thing. Is Nepal Medical Council, as a dean also member of that council, is very strong. They are strong Nepal Medical Association. They can put anything in the council or association, and the government will accept that. Okay? They will be directly appointed in 8th position, 9th position, maybe tomorrow 10th position. Right? Because doctors have a role model since the establishment. It depends. For last 27 years, we are producing the graduate, and we are knocking the door of government to have a council act on healthcare management. So we actually met when Dr. Ashok Rai and the Bamshidhar Mishra was the minister, Mokman Sikarki was the secretary. Long before that, the Srikant Ring was the health secretary in that time. I met with him when the college was started in 2000. So I met with him. They promised to have a council act. At least, if not for the time we get the council membership from NSPC, still not. So now time has come. There should be a regulatory body on education which must impose the eligibility criteria, which must impose the criteria for the running the education and training, which must impose the membership of the council. Is that agreeable to you? Thank you so much for passing all the 4 decisions that has been proposed during this seminar. I will not take much time. I just thank all of you once again from the heart of my heart and mind also, and on behalf of college also. And I also like to thank all the Indian delegates from IISMR, Dr. Professor I have the problem of pronouncing your name, Dr. Nidhi, Dr. Puneet, for coming over here and taking all the sick pain of travel, leaving their family back. I once again thank you all, and I wish you a happy life ahead. Thank you very much.
Ladies and gentlemen, this brings us to the end of today's program. Thank you all for your participation and valuable contributions. We now invite you to join us for a tea and networking session. Please take this opportunity to connect, exchange ideas, and continue the conversation. Thank you once again. Have a wonderful evening.